We're now going to go back to what was to be our first session, and that titles is Getting a Handle on EVM, clarifying the basics and how and where it applies to veterinary practice. And we have two speakers who are going to deliver this session, and I'd like to leave any questions until the end of both speakers' talks. Our speakers are Dr. Sally Everitt, a veterinary surgeon who spent most of her working life in small animal practice, but in 2011 joined BSAVA as Scientific Policy Officer. Sally joined the SPIVS Masters Group led by Bradley Viner, looking at clinical audit in the veterinary profession, and I believe is currently doing a PhD, or has done a PhD, pardon? Finished PhD, looking at clinical decision-making in veterinary practice at the University of Nottingham. And closely behind Sally is going to be Pam Rosedale, who I know pretty well. Qualified, she was a partner in a veterinary hospital for, I can't believe it was 17 years, but I'm sure it wasn't that long. Then she took on the role of practice standards inspector from the start of the BSAVA, which then moved over to the RCVS, and she's now senior inspector. So, not now, okay.
Good morning. As Jeff said, I'm Sally Everitt, and I have spent most of my life as a practitioner in predominantly small animal practice. However, while I was in practice in Buckinghamshire, I also became involved with the local Community Health Council, which was the predecessor of the current primary care trusts. And because we were in the Anglia and Oxford region, we were all given basic training in evidence-based medicine and critical appraisal skills. And this was in the mid-1990s, so this was relatively early on. And I became quite interested in how we could adapt and apply these things to veterinary practice. So this very brief overview is going to go through some of the ideas of evidence-based medicine and also perhaps discuss some of the problems and barriers so that as the day progresses we can consider how we might deal with them. So evidence-based veterinary medicine, it's been discussed as a new paradigm, but actually it's really an evolution of a lot of things that have gone before. The first picture there is of James Lind, who's often credited with undertaking the first clinical trial. He was a naval physician at a time when most of the sailors in the Navy suffered from scurvy. It had already become apparent that this may be in some way related to diet, but it was him that carried out the clinical trial that actually established that this was related to vitamin C and citric acid. I don't know if this is good news or bad news for those of you who are in research, but although he published his first paper in 1753, it wasn't until about 50 years later when the work was taken up and actually citrus fruit was available in sufficient quantities to be available to all the sailors and therefore get rid of scurvy. The second picture is Archie Cochrane. He was a Scottish doctor who during the Second World War found himself in prisoner of war camps where he was treating and living with his patients. And perhaps because of this, he was able to see at first hand what his treatments were doing, and he became convinced that we didn't have enough evidence about what we were doing, and later became a massive advocate of randomized controlled trials, and eventually this work and led on to the development of the Cochrane Library, which was named after him. The final picture is of Dave Saket, who was Professor of Clinical Epidemiology at McMaster, and he was one of the group of people who was really sort of preeminent in producing the current ideas of evidence-based medicine, particularly critical appraisal skills for practitioners. The purpose of this slide isn't just to suggest that this has been a few people, but really that evidence-based medicine has its roots in things we've always done, that medical science has been based on observation and analysis and appraisal, but perhaps now we're just in an information age starting to approach this in a different way. Evidence-based veterinary medicine is obviously at a much earlier stage. We have some real problems with both developing and accessing high-quality evidence. And there are some significant differences between medical practice and veterinary practice, particularly in the relationships that we have with the owner and the owner has with the animal, and the fact that everyone is paying directly for their care. But we do now have a Centre for Evidence-Based Veterinary Medicine, and Rachel is here, and Douglas is here. Lots of them are here, and I'm sure they'll all be happy to talk to you during the day. So evidence-based medicine, what is it? The first part of this quote, evidence-based medicine is the conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients, is regularly quoted in all sorts of places. This is one that came from Dave Saket and people at McMaster. However, the second part, which actually explains what he means by evidence, is often left out of the original quote. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. So that starts to talk about what evidence might be coming from systematic research and the fact that in some way we need to start integrating it with our practice. We now also, courtesy of the Centre of Evidence-Based Veterinary Medicine, have a veterinary definition. Evidence-based veterinary medicine is the use of the best relevant evidence in conjunction with clinical expertise to make the best possible decision about the veterinary patient. However, we've got a bit extra on the end. In addition, the circumstances of each patient and the circumstances and the value of the owner-carer must be considered when making an evidence-based decision. And that tells us something about how we have to start to think about our evidence. So what do we mean by best evidence? We've already been told that this is only one way of looking at it, but it's very frequently cited that there is a hierarchy of evidence with randomised controlled trials and particularly systematic reviews and meta-analysis at the top. But as has already been mentioned, this really only relates to intervention treatment trials, and for other sorts of questions, of which there are many in practice, we need to look at other sorts of evidence. But what it does do is put all the systematic published research at the top and consider things like ideas and opinions and perhaps more basic research at the bottom. So trying to look at the fact that different sorts of questions need different sorts of evidence, the Centre of Evidence-Based Medicine in Oxford have now drawn up a grid of the sorts of evidence that might be appropriate for answering other questions, questions related to diagnosis or prognosis as well as treatment. But all of these things talk about published evidence, and we have to think that there are different sorts of evidence that we might need to consider, particularly when we don't have published evidence available. The first, and at the top of the list, is still empirical evidence derived from clinical and in some cases basic research. But we also have to bring in our experiential evidence derived in the course of our practice. Pathophysiological rationale has already been discussed, that it's necessary but not sufficient, but on occasions it is necessary. One of the papers in the BMJ pointed out that we don't need a randomised controlled trial to show that you should use a parachute when jumping out of an aeroplane. But we do need to be careful about what we think we know. Last week I was asked to look at the evidence relating to disc disease in dachshunds, and a lot of people seem to think it was related to the length of their back, but all the evidence to date, and admittedly there's not a great deal of it, suggests it's actually related to the shortness of their legs. Patient goals and values and the circumstances in which treatment are carried out. Lots of people say that that's not an area of evidence, but it is an area where we need to collect careful information if we're to give the best treatment to our animal patients and satisfy their owners. There have also been a number of criticisms of evidence-based medicine. The first is that it interferes with professional autonomy by replacing professional judgment with protocols and guidelines. It's also been argued, and we heard earlier on, that it provides a way for junior doctors or clinicians to question the authority of their superiors by using evidence-based techniques. In the medical field, you may want to disagree, this seems to have become less an argument between doctors and perhaps more of a question of who should make the decisions. Is it doctors, or do managers and insurance companies have a role in making these decisions? And I'll leave it perhaps for discussion later today as to whether those are things that will become relevant in the veterinary field. There is always a problem of the application of research knowledge to individual patients. Research is carried out on a sample, and that sample will be selected to control for various factors. One of the problems we had until recently was that a lot of the research in the veterinary field was carried out on a referral population, which was sometimes significantly different to those cases being seen in first opinion practice. But there are now an increasing number, with SAVSNet, Vet Compass and the work at the Centre of Evidence-Based Veterinary Medicine in Nottingham, looking at doing research on primary care cases. We also have to remember, and this is a big problem particularly in dogs and cats who are living to older ages, that comorbidity is virtually always ruled out of any randomised controlled trial because animals with other conditions are not eligible, and we frequently treat animals which have multiple problems. There have also been criticisms of evidence-based medicine about their knowledge claims, and this is a bit more about what is good evidence. This is that some people have been suggesting that the evidence, information derived from published research, is not so much evidence which needs to be judged, but is in itself objective truth. I think the modern views of evidence-based veterinary medicine and veterinary medicine, which look at critical appraisal, sort of counter this to some extent, that even published research needs to be judged. And as came out in the question earlier on, to date there has been very little evidence that evidence-based medicine in itself can improve patient care. I'm now going to hand over to Pam, who's going to talk a bit about her experiences of practice, initially as a BSAVA and later an RCVS inspector.